I've been given the word. uh, Today, the talk will be on cholesterol issues, lipid issues, lipid management issues, and of course, and titling this for secondary prevention, because clearly, we like to have that nice normal artery to begin with, and that be the way we are, but here in cardiac rehab, we're actually dealing with different stages that have happened for those that have gone through interventions and either had stents or had bypass. There's different ways that atherosclerosis can progress. Clearly, atherosclerosis is not just a issue with cholesterol or issues of lipids, but lipids play a big role in this, and we'll see, as we'll see, and going through this, clearly other issues, high blood pressure, diabetes, cigarette smoking, all those things can play a role in atherosclerosis and progression. Clearly, we always have to try for primary prevention, if you will, never to have a problem happen. And with this, our lifestyle is important with this from an early age, and so kids being more active, kids eating and understanding proper nutrition, and as we were just talking, my kids were raised on cheeseburger, fries, and grilled cheese, that type of thing, and yeah, there's places for that, but not daily, and clearly, you combining poor nutrition this day, we're getting a lot of calories, but not a lot of calories burned. Then we're also running into the problems of childhood obesity and its problems that are going to spin off, and there will be the future patients in cardiac rehab. So cardiac rehab is secondary prevention. A problem has happened. People have had a heart attack, a stent, bypass. Other reasons people are in cardiac rehab for congestive heart failure and also for heart valve procedures. So we do the initial assessments, we prescribe exercise and nutrition, and we're trying to guide people back toward health and, if we can, toward preventing this from ever happening again, and possibly for even some degree of reversal. The risk factors of the past, as we've talked, Framingham, it was a big study, really looked at risk factors for coronary disease, and it was kind of the later 50s and the 60s and on. Framingham has defined those as cigarette smoking, elevated LDL cholesterol, a low HDL cholesterol, a family history for premature coronary disease, and age. What we're up against today, the two risk factors that have combined to be worse than cigarettes, and that's inactivity and poor nutrition. And with this, I think the diets have changed. They've become more this calorie-rich and processed foods that really are more atherogenic. And you combine that excess calorie consumption, you're going to get weight gain, because there's just no way to burn everything you consume and not start developing obesity, or at least that tendency toward obesity. Obesity, as we've seen, can be defined by the height, weight, BMI, but also everybody's had the chance of going through the BIA, or bioelectric impedance analysis, and it defines obesity by percent body fat. So there actually can be someone who's even normal weight and yet obese, and I think that's important. It was eye-opening with our experience of what we began to see, and the ways we were trying to get people to do these activities with that is exercise, and then improve the nutrition all along the way, and see those changes in whether fat percent or muscle percent. and hopefully to see the fat mass coming down and the muscle mass going up to get this improved ratio over time was really our goal. As we get this higher fat percentage, then that tendency toward insulin resistance begins, and it begins earlier. Everybody's just saying, well, I'm just pre-diabetic, or I'm not diabetic. Well, you're still insulin resistant because you've got the following going on. And insulin resistance is a bad thing, and we've talked about it in other ways that cycle can get going and then stays established. And unfortunately, the higher the insulin levels, the higher the fat storage, and the more difficult to break out of it because you stay also hungry. And then you're hungry for the wrong types of things. It is a bad cycle, and breaking out of it is not easily done. So insulin resistance can be very silent, and but the consequences expressed much later. 3 words in this talk that you're going to hear: lipids, lipoproteins, and apolipoproteins, and we'll try to separate these. Lipids are basically fats and oils in the body, and of course they don't circulate freely in the body, thankfully, because our body's mostly water, and water and fat don't mix, and they're not soluble, and I mean it'd be a big mess. Well, how do we deal with that? Well, our body, as we eat, we absorb. As soon as it's coming through the intestines, they get to what's called the enterocyte. And the enterocyte starts coating this fat with protein. And protein can flow through the body, like our red blood cells. So here we can have something that has cholesterol and triglycerides combined, be wrapped in a core of protein, and then circulate through the body. Well, interesting, as we'll find, there's 2 types of circulations that actually, there is the blood circulation, but there actually is the lymphatic circulation. And a lot that we eat, especially our fats, go through the lymphatics, straight on up through that, actually come back in through the superior vena cava, and actually go into the heart initially. And I'm like, why were we designed to send fat directly to our heart? Well, actually, it uses it as fuel. Those free fatty acids, the sugars, the heart wants that. It's like a hummingbird. It wants to see something it can just use directly as fuel. And so it is amazing that we were designed that a good bit of the fat coming through our chylomicrons and up to actually go through the lymphatic circulation. The rest is in the circulation and ends up back where the liver, a very important factory, really starts processing things. Well, there's a little green thing called the apolipoprotein. That's like a little tattoo. It's a protein tattoo, and identifies that as a specific type of carrier. And the liver knows that tattoo. And so it will see it and process it the way it needs to. So it's interesting. We eat, we absorb, this get wrapped, it's labeled, it starts circulating, and then we'll see all the things that go on during the circulation, because these wrapped areas are called lipoproteins, and we'll see they're good and bad of lipoproteins. As we'll see with the apolipoproteins, there's also good and bad. So cholesterol, we all need cholesterol. It's a fat-like waxy substance that our body makes. We don't actually need to eat any cholesterol. We can make it. And what do we use it for? Well, our cell membranes. It keeps, our cells as cells. They have a structure. They're not like plant, cell membranes, because we're animal, but it's a waxy lining, and it actually keeps water to some degree out, or at least it defines how permeable it is going to be. There's also other hormones that are made, and vitamin D is made. And we'll talk later. Actually, coenzyme Q10 is part of the cholesterol pathway. So in production, cholesterol is either absorbed in our diet, and like I said, we don't have to, or it's synthesized in the liver to some from a precursor molecule. The hepatic cholesterol synthesis really follows along this path, and actually you'll see that this coenzyme reductase is a certain protein. It's called HMG-CoA reductase. Is part of that process of it making its way toward cholesterol synthesis. So somebody says, well, if that's in the process, I think we've discovered a way to block that. So along comes the HMG-CoA reductase inhibitors, or statins. And so our statins came about even recognizing that even in certain fungus on the red rice, or I should say yeast, on red rice yeast, that this yeast was found, and lo and behold, it had this property of blocking cholesterol synthesis. And so they work in many ways, and the problem is in any pathway, if you block at the above a certain level, what does it affect downstream? And so the next stage is what's called mevalonic acid is produced. And what's mevalonic acid used for by the body? Well, coenzyme Q10 of all things, which plants and animals have this for many different purposes, and so that's been thought that the buildup or the absence of the mevalonic acid can lead to this problem with muscle and the muscle soreness, and some people are more sensitive to it than others. So we'll talk more about that. Animal products that have cholesterol, clearly, animal products have cholesterol. The milk, eggs, meat, cheese. I mean, so plant foods and plant products do not have cholesterol. So it's just, so we do not need to eat cholesterol. Our bodies will make it. It makes what we need. The blood test, or chemical analysis of our blood, it calculates the amount of cholesterol we have in it based on kind of color of light emitted after it reacts with certain chemicals. It's kind of interesting. So both our cholesterol and cholesterol esters kind of have a certain degree of reactivity and a certain amount of light, and there's these sensors. I picture this yellow light, but I'm not sure what the color is, but that shows the presence of cholesterol and gives you a cholesterol level. As we talk, there's these lipoproteins, and there's 5 different types. There's these large chylomicrons that are mostly carrying around triglyceride within it. There's the VLDL, just a little bit smaller, an IDL, an intermediate, and then it makes its way to LDL, or the low density lipoprotein. And of course, you have this high density lipoprotein that's actually smaller but more dense, is called the HDL. And as we know, we talked about the LDL is bad, the HDL is good. We'll talk about reasons why they get that designation. Triglycerides is interesting. It's a measured type thing. So cholesterol is measured, triglycerides are measured, and actually, of all things, HDL is measured. LDL is calculated most of the time. We'll go through that, but this measurement can be done by, once again, this enzyme breakdown, and then sensors, and they're actually trying to hydrolyze the triglyceride to just glycerol. So it's breaking it down, and then it counts cholesterol. And from that, it must divide by 3 or something like that. But that's what I kind of picture. I don't know that, but triglycerides are made in the liver. But the neat thing is it's a measured. So you've got total cholesterol measured, triglycerides measured, HDLs are measured, and then LDL is calculated. There are newer things that are direct LDL measurements, and we'll talk more about that. Triglycerides, what situations raise some health conditions, kidney problems, diabetes, liver disease, just being overweight and obese, thyroid disease, and of course this cardiometabolic syndrome with insulin resistance becomes the wrap all with that. Triglycerides are higher when you don't exercise, when you're eating food that's high in fat and sugar, and when you're drinking too much alcohol, which is the sugar. You know, you just have to picture alcohol as a loaded sugar. The standard profile that we usually see is the total cholesterol, triglycerides, HDL, VLDL, and then a calculated LDL. You can get some calculations where they do it for you or not. What's called non-HDL. That is, sometimes it gives a clue of the things that may be more atherogenic, those things that are not HDL. And you get that number. And then there's always the ratio of the total cholesterol to HDL, and that will sometimes be calculated. And it gives risk, type things as you see them. LDL, as we talked about, is a lipoprotein. Inside of it is a lot of cholesterol, and it's mostly cholesterol. It has a little bit of triglycerides in it, but mostly cholesterol. And the bad part about LDL is it adheres to it attaches to our arteries and the walls, and then over time can get absorbed within it. It can be part of it, especially in a process called LDL oxidation, and that's a whole different topic, but there are types of foods that we eat and things that can oxidize our LDL and make it more sticky and make it stay and make it more irritating to the lining. If we're lucky, LDL may get within the vessel lining, but then get taken away by the HDL at a later time. So our HDL carries it back to the liver for further processing. LDL, as you said, is calculated back in 1960. A scientist, Dr. Friederwald, came up with a formula, and it's LDL is equal to total cholesterol minus HDL minus triglycerides over 5, and this becomes the number for LDL. So you can see this becomes a big problem when the triglycerides are real high. If the triglycerides go over 40, then you've got a number that's going to bring LDL down probably too low, and it's be falsely low. So a lot of times if your triglycerides are over 400, they don't even, it says LDL cannot be calculated. And it will say that. And by the way, everyone who sent your lipids, everybody's lipids were great in here. Y'all are either doing much better than I do, or you're following your physician's advice, or you're doing something right. And I had none to show that were, let's show this one to show how we might improve this. Your numbers were great. And so I brought those down, but Nancy gave me a collection of them, and nobody's numbers were bad, which is wonderful. But the question is always, how did he get there? Is it dietary medication? There are these wonderful meds out there too, and we will be talking about that. So there is this direct calculation of LDL that is going on, especially as we're seeing more and more cardiometabolic syndrome, insulin resistance, higher triglycerides. Where we need to know the LDL, and if we're going to manage it, we don't want a falsely low LDL value because the triglycerides were elevated, and the calculated LDL therefore ended up being lower, and it kind of lulled us into a feeling like, oh, this is good, your LDL is good. Now if you see the triglycerides up and they're over 300, that LDL may not be correct, and that is a problem. So it may not be accurate, and I think you have to look at the numbers. When triglycerides are up, the LDL may not be correct. HDL, we're talking about, it's good. It carries cholesterol back to the liver for further processing. And what does the liver do? Well, the liver does several things. It gets rid of cholesterol. Some of it's in bile salts. It uses it as a detergent, to absorb fat again. But that's what bile salts are for. They're detergents to fat. Their LDL itself has a bit of a reabsorption downstream. Why we try to hang on to LDL, I'm not fully sure, but there is this resorption of LDL. But if you're a high fiber diet, you'll flush it out, and that's where even things Metamucil, Citrasil, even other medications that are used to stay in the gut, to bind the binders. They were hard to people to use because they got real gassy, and it was you could recognize the people that were on the binders, but so most people didn't like using them. There's too many other options. Low HDL can be genetic. It can be from low activity. It can be from cigarette smoking. So improving the activity and stopping cigarettes are the only other ways you can do it. Lifestyle, with a lifestyle change that may affect and raise HDL. You cannot significantly raise your HDL with alcohol. It raises the wrong and improper HDL. It's an inactive form of HDL. So all this, even cardiologists with red wine and guilty, it actually does not tend to raise an active form of HDL. You're going to have a more effective HDL with physical activity and stopping smoking if you're a smoker. You can measure HDL with some other methods. Best may be with the NMR, but we don't have a lot of things we send off for that to be done. There's an ApoA, and it's the good one. It's that little tattoo on the outside of the lipoprotein that actually is recognized as this is a good one. This one's on our side, and usually you'll see when triglycerides are high, HDL is low, and then the opposite. It seems to be inverse. When the HDL is high, the triglycerides, or at least higher, the triglycerides come down. Chylomicrons, these are big things. I mean, that circulate, and they're kind of this is why a good bit of it goes through the lymphatic system. For it's very triglyceride rich. It's just basically kind of a fatty core with a little rim of protein and around the outside, and even it has a little tattoo mark, an lipoprotein. VLDL is kind of one of these intermediaries, but it actually does have a lot of triglyceride in it. It also has cholesterol within it. It's processed by the liver. So here's a picture of our lipoproteins, you see the comparatively the chylomicron's really big. The and the blue is mostly triglyceride, and then you get a chylomicron remnant that's about the same size and looks very similar to VLDL, but VLDL came from the liver. The chylomicron remnant was after intestinal absorption and circulation, and it just breaks down. So they're slightly different. And, one was more of a breakdown product. The IDL a little bit smaller, low density, lipoprotein, LDL, the bad guy, and then HDL in different sizes and forms can be measured. But what we found is always large is good and small is either not working for you or is bad. This is breaking down the apolipoproteins. The key one to remember that's bad is B. B is bad. So ApoB. And ApoB has two sources. The first source is actually intestinal absorption and what's made quickly by way of the intestine. But then and that's more the chylomicrons and the chylomicron remnant. So that's one form, and they're still bad, but the really bad guys are the ApoB 100s, and these are VLDL, IDL, LDL, and LP little a. This is a form of LDL that gets kind of wrapped in what's called a kringle. It's that little, and that Apo little a is actually the kringle attached. It's kind of like a little tail, or somebody liked the word kringle because it sounded like some form of a donut. But it's, these are bad, and so and we're finding the LP little a is underdetected. Is typically not measured as LDL. It's kind of a stealth LDL. So if a person had a high degree of high level of LP little a, it may go unmeasured unless you measure ApoB. And all of a sudden you see, well, gosh, that's really interesting. My LDL is normal, but my ApoB is really high. Which one of these other bad guys is it of the four? So these, it's interesting because it does get more complicated. We're now finding direct ways of treating LP little a. And years ago, we thought there was nothing new, so why measure it? Now we're coming up with medicines to lower LP little a and being more effective. Even the Repatha or the Praluent, they lower LP little a little bit. They're not really directly doing it, but it actually does help. But those are your bad guys. The ApoB, B bad, and your 100s. But it includes all, and then the A is separately measured, but actually in the ApoB 100s, you'll see that there actually is the little tattoo that marks it, that the body knows that's a bad guy. So as we said, there's two forms of ApoB, one that's coming from the intestine, the ApoB 48, and then from the liver, the ApoB 100. And it's that hepatic ApoB 100s. Those are the really bad guys. So overproduction of that or underclearance of those would be bad in the body. So ApoB, just showing its form, but just that it includes those four areas, and significant elevation of the ApoB is an issue. So we've got the ApoB, we can measure and count it, it counts every single atherogenic particle. That's what's cool about ApoB. You get a number, every single one of that count is something bad. And it really, I think in ApoA, every single one of those particles are good. So you can actually get ratios, ApoB to ApoA ratios that may be real significant. You can actually measure an ApoA, and that's another way of counting LP little a. So you just even those three tests. But like I said, that the LP little a is in ApoB. It's being counted in that. This was just showing intestinal absorption, how we circulate the liver. I mean, in each particle, how much cholesterol, how much triglyceride. But it is interesting. It says LPL. That's lipoprotein lipase. That's the enzyme breakdown for things in our body. And actually, we'll talk later that we need an active lipoprotein lipase. That if we get an inactive breakdown product that actually happens in insulin resistance, that's another problem. So another big problem with the metabolic syndrome or insulin resistance is it inhibits or lowers the effectiveness of LPL or lipoprotein lipase. So insulin resistance creates what we call the metabolic syndrome, in that we get this more atherogenic lipid pattern. It's typically a smaller LDL. It's a high triglyceride. It's a higher level of LDL and some of its precursors. And so we'll redefine cardiometabolic syndrome. This is typically involves the abdominal obesity, the atherogenic hyperlipidemia, high blood pressure, insulin resistance with glucose intolerance, the tendency toward higher inflammation, pro-inflammatory states, and the tendency toward clotting, easier to clot. So this prothrombotic state. So all of those are not good. We look at the pattern. It's the elevated triglycerides, reduced HDL, and high and predominantly small LDL. And that's the first time I started mentioning size. So size matters. Large is good, small is bad. And there's a different type of measurement. We'll see they're called a VAP or vertical analyzed panel. It's a density gradient that separates it out, or the electrophoresis, or the NMR, or there's even a thing called the ion mobility method. All of these separate these lipoproteins not only into the different groups but different sizes, and so then you can count these particles, and you can count. It's I think with ApoB coming along, it's kind of neat just to know one number, not to get this big readout. If anybody ever done electrophoresis, had that sent off, the lipid clinic does it, but I'm telling you, just getting an ApoB right now tells you it's the count, and that's it. So I'm starting to use ApoB a lot more in my looking at things and looking for whether I can still trust my LDL measurements as being correct or not. If I can, then I keep using LDL along the way. If all of a sudden I see I've got this discordance between the two for whatever reason, now I need to follow APO and measure it that way, and then follow it, because now I know particle counts. I've just got to go after getting APO and be lower. So as we said, insulin resistance can lead to a lot of things, but with the lipoprotein lipase not working as well, the VLDL starts not only being overproduced but doesn't get broken down, and it doesn't clear the triglyceride-rich ApoB particles. You start getting this high LDLs, high triglyceride, this mix, that mixed hyperlipidemia, and that goes along with insulin resistance. And you get a lot of free fatty acid release from the fat cells. You know, we'll talk a little bit more about where size matters again, and that's that fat cells. We only have a certain number of fat cells in our body from birth, and guess what? We just pack them more. You know, so fat cells don't increase in number; they just get more swollen. You know, it's just, you know, so we fluff them up more. You know, it's like a trash bag that just keeps expanding. You know, and that's what they are. So size does matter for fat cells because of this release. At a certain size, they release a lot more free fatty acids into the circulation. And the location matters, as we've talked about, being more that visceral, abdominal seems to be bad. But we also, it starts getting bad where it gets stored. Like, is it getting stored in the liver? Is it getting stored in the muscle? Is it getting stored in the pancreas, in the kidney, around the heart? All those things, you know, location starts mattering, you know, also. So this was kind of interesting because sometimes without obesity, they're always trying to figure out why someone is still prone to having high triglycerides. Some of the medications can affect things. Of all things, the antiretroviral things for like HIV treatment, you know, and can actually raise the triglycerides significantly, and actually lead to even muscle loss. So they get muscle loss, you know, high triglycerides, and then they have, it's interesting, kind of a much bigger metabolic problem. Lipoprotein lipase we talked about, and that's somehow is a little less active here. So let's see. Nutrition. You know, clearly, you know, our standard American diet, or calorie-rich and processed diet, is just really, you know, sort of sad or crap. You know, I mean, it's just, it really is. And 70%, you know, of our nation's diet is that, and it is sad. And obviously many reasons, you know, food deserts, etc., lack of, you know, proper availability, but it's still sad, and one of those issues that the nation's going to have to address if we're really going to tackle our bigger crisis. If we spent more money on improving nutrition, you know, in this nation, we would be spending a lot less money down the road, you know, and the way we're having to use the high-tech, high-cost care. So this would be the highest value, low-cost care, is to get improved nutrition in the United States, and then get everybody moving. Get physical education back in the schools. Everybody else, we have, you know, lunchtime breaks in offices, and we go for a walk, you know, whatever. I mean, just something. We go do something, you know, instead of just go take a big lunch break going through the drive-thru. Yeah, I mean, that's you know. So we need to tend more toward the some other country, whether Mediterranean, but just more whole food, plant-based in its start. How to treat hypertriglyceridemia, lifestyle changes, weight loss, Mediterranean diet, lot more polyunsaturated fats in the diet, and not just the fish and fish oil, but the even flax seeds, chia seeds, you know, the olive oil. Obviously, those are the types of changes. Decrease the carbs. I mean, yeah, the sugars. The really, and it's, you got to be always careful, because someone just says I'm decreasing carbs. You know, sometimes they're decreasing good carbs. You know, things that had the fiber, had the and the, you know, what they really should be is just sugars. You know, and that's so. And eliminate trans fats should be 0. And then clearly, as far as the weight loss, you know, really, well, this says 30 to 40% reduction we've seen with the above changes, and that's true. A lot of times, lifestyle changes can lead to this. Weight loss begins seeing a difference at a 10% weight loss. Just wanted, so 10%, they're overweight. If you lose at least 10%, metabolically, you know, you're going to start getting things more correct. Medications, niacin was used years past, less common use, but still around. Fish oil tablets, fenofibrates, very common for those two. LDL, 3 problems with LDL in the body. One is we overproduce it. It's what our body's making, and it's what the liver's making. The number 2, it's not clearing it as well, and we clear it in our liver and our gut. Those are the 2 places LDL gets cleared. And number 3, we're absorbing too much from what we eat. We're getting it in our diet. So those 3 areas, if you can affect production, clearance, and absorption, then you can really attack LDL. We'll go through that. So medications, statins, you know, clearly niacin was actually one of the first. If you look back, you know, historically, niacin and some other binding agents were being used, trying to clear it in the gut. But along came HMG-CoA reductase, and clearly game changer. I mean, I know for my dad, even before the multi-center trials had come out, Dad had already recognized that my father, that this was important, that even with Mevacor, the granddaddy of them all, I'm going to put people on this early to prevent problems down the road. And he followed that and tracked it, and followed about 3,000 patients. And my mother kept little cards on all the patients, and things, how many times were they readmitted and what their levels were over time. When they came out with these big multi-center trials, when Dad showed these to one of the companies, they had Dad answering questions at a meeting, and everybody wanted to ask him, because he was the one with 3,000 patients. All these other people were just the people with the data. But they wanted to know, what do I do with this? What do I, and they were all, so it is neat. And long as come ezetimibe that blocks reabsorption, so it kind of clears it, it acts at the gut level to decrease absorption of fats in the gut. PCSK9 inhibitors, a game breaker. I mean, just amazing. Repatha and Praluent. What is PCSK9? I asked my dad one time, why? You know, and well, basically it is Roundup to it's a protein made by the liver, but it's Roundup to the LDL receptors of the liver. And what happens is, you know, when there's less LDL receptors, we're basically not clearing our LDL as well. It's not binding, being reprocessed, being sent away. Well, we use the PCSK9 inhibitor, and the next thing you know, you get more LDL receptors. They start blossoming and growing, almost like, you know, the chia pets. I mean, you get this bloom and everything, and then next thing you know, everything can take that down. In fact, significantly. I mean, you've got several patients who, you know, come in with LDL of 20. You know what I'm saying? LDL 30. You know, Never seen those numbers, you know, for people. And by the way, it's not an issue. I mean, it's not harmful. Every single level that they've come down is another improvement of outcome. Inclisiran's a little bit different. It's a silencing messenger RNA living in the liver cells for 6 months and reducing the production of PCSK9. Bempedoic acid, real neat. About 2 steps above statins is this newer medicine that I cannot get. I prescribed it and we cannot get access to it. It's been terrible. It's over in England. We've seen all the data coming out. It looks very good. The muscle problem doesn't seem to exist. It's about 2 steps above, and maybe somehow, some way, it doesn't affect the coenzyme Q10. That's the serious. No one knows. There's still, but they're just not seeing the muscle problem with it. It's just, I think it's just so new. It's not come out. So statins, ezetimibe, sometimes used together. Statins, PCSK9 inhibitors, and if needed, ezetimibe, you know, can be used. They're all different mechanisms of action, all just trying to lower LDL. Bempedoic acid's not in this one, but inclisiran mentioned its process is to reduce PCSK9. My wife, who's a pharmacist, says, "What if there's a side effect?" I go, well, let's hope there isn't, because that's a 6 month in the liver cell, you know, type of thing. So we've not heard of any that to speak of. It is an infusion, and so having to have an infusion pharmacy to give this is really interesting. So it's actually being created at the Walgreens pharmacy near the hospital across the street. They're setting up an infusion setting. It's not there yet. Bempedoic acid, once again, is just interesting. I find it fascinating. It's just I can't get my hands on it, and but it stays away from the muscle symptoms. And I think here's a pill, daily pill that can be taken, and not need an infusion. And if it had the effectiveness, you know, wouldn't have to go through all all that, even though the others are every 6 months, to have to give infusions is an issue. What's our goal? LDL. The initial goal is really to try to get things around 70. If you had a problem, had coronary issues, 70, under 90 initially is good, getting it close to 70 is the goal. 50, actually, the number 55, it seems to be ideal. Something about 55 over in Africa, away from any kind of cultural influence other than the human body seems to have an LDL of 55. And no coronary disease. No coronary disease. So that's an interesting number. So aggressive reduction with combination of nutrition changes and medicines, I think, are sometimes what we have to do once there has been an issue. To just rely on, I can do this alone, I can do this with dietary change, it just may not happen. Newest agents really don't have the outcomes, that is, they've not really shown the test of time of reduction of MI, stroke, death, what we call the major major issues that we're trying to make changes. But so the Lp(a) is getting more and more in the news. This was kind of a couple of years ago. This showed up as a separate journal to me, but now that there's treatments and things, infusion treatments mostly, there is a pill or tablet treatment coming along. Almost done. I'll go through this. I mentioned my thoughts that coronary artery disease is what goes on after you eat, and we don't really measure that. We measure almost everything we do fasting, and so there are these ways for insulin, for glucose, and now even for triglycerides that they're doing testing. So you can measure a glucose tolerance test, 70 grams of sugar, and follow the effects in 1 hour and 2 hours. Of all things I found, there is a triglyceride tolerance test. I went looking for it. I've never done it, but it's measuring, and I've tried to find what the range, the normal goal is. A normal fasting triglyceride should be 90. You know, should be 90. We always try to get people below 150. You know, that's the initial goal. But really, what should be the ideal would be 90. The postprandial, or 1 hour and 2 hour, being above 220, you know, is abnormal, and so it shouldn't be going that high. And this may be from this overabsorption, what we've just eaten, under clearance, that the enzyme's not breaking it down as fast. And Dr. Joel Furman actually wrote this book, Fast Food Genocide, and actually did show what fast food was doing to people. And actually, they not only kept high triglyceride levels for about 4 hours, but they actually kept inflammatory markers for 8 hours. And so it's an interesting book to read. It'll make you skip the next one. You take, like my wife and I were traveling to Atlanta this afternoon, where she's making our supper, and tuna fish and stuff, and she's trying to hit the road. But what do you do when you're traveling? You're traveling. If you're not preparing, at least for the one meal, or it's multiple meals, you really are at the mercy of what's out there. And of course, you know, the line to the left is shifted a little bit more to the right, if we can. We've talked about the marbling. We'll keep talking about that in here, because I'm not going to give up on it, because I think that's where fat's getting stored is a big issue. The enemy got different when it became obesity and insulin resistance, and I think that our labs are going to have to change. And this is, you know, not only measuring fasting lipid profiles, but some people actually have to go more direct, you know, measurement of LDL or ApoB, as we talked. That is a good way. The triglyceride levels, if somebody had a problem, it'd be fascinating to see a triglyceride tolerance test and what level they went to. There are brand new infusion medicines for people that chronically have triglycerides over 500. They just have come out, and some people will have them well over 2,000. I mean, it's very, very thick. Pancreatitis can occur. An anaconda eats a deer, its triglyceride level goes to 10,000, and it has to create TPA to keep its blood from clotting. Now go picture the person who drew the blood of that snake. Someone had to measure all that. So, but that's a true story. They eat a deer and it goes to 10,000, and they would die if they didn't create a blood thinner. So they do that. There's some interesting labs have been finding for fatty liver. There's actually a FIB-4 testing that can actually show what level of fat and cirrhosis the liver's at. And I thought that was fascinating as we get into more problems with fatty liver out there. That's an enemy. The insulin resistance tests, the HOMA-IR, insulin levels, measuring a little bit more of. It's fascinating, the inflammation side of it, the high sensitivity CRP just really is still not the best thing. I mean, that came out, I thought that was going to be a wonderful marker, trying to get people down. It comes down, but I also don't have a lot of people that it's really high. So it's really not picking up, so it may be specific for those that have a problem, but you're not very sensitive to try to detect a problem going on with people. So I don't know, it's interesting. I think we do want to keep our overall body inflammation low. I think there's, of course, risk of cancer, dementia, all those things are still part of that. Another topic. ApoB to ApoA ratio, it's interesting to you can have a normal LDL and have an abnormal ratio be picked up, and that's really interesting. I think maybe that and I've just been trying to see, do we have LDL concordant? Is it still predicting it in the same type range? It would be bad to find the ApoB to be abnormal and the LDL to be normal. And then we missed a lot that's going on atherogenic that's not being measured. Insulin resistant labs, that's the fascinating one in that is the lactate level, that a person at rest without activity can still have a high lactic acid level in their body, meaning that their muscles are just that poorly effective. We should have Tour de France competitors real high VO2 max, therefore their lactic acid level doesn't go up until they're really in the high Alps and for many hours. Whereas the person just at rest with a high lactic acid level means they're already gone from where they've utilized every bit of their oxygen they can, and now we're making lactate. It's that, and that's a measure. We need to combine lifestyle changes with these medicines, otherwise the list of medicines will just grow. We need more physical activity. We need better choices of food and more whole food, plant-based nutrition. CoQ10, maybe look back on this, but it's been helpful, but the supplement doesn't always prevent the statin type muscle problems. There's still some. So is the story all about CoQ10? Are they getting a high enough level? If it is a problem, no one's done a study that really has done. No one's, none of the statin companies were ready to invest in it. It is amazing. Here they have a problem and they don't invest in a study how to change it. So, summary. Thank y'all for listening. But hopefully this helps to improve your understanding of lipids. You need to know your numbers. You need to know the goals that you need for control. Insulin resistance has increased and can even be present without knowledge of it increasing your sugars to not even pre-diabetic with your hemoglobin A1C but you can have it, and some of these, as these atherogenic particles start to show up, and I think insulin resistance needs to be considered more and more. I see so many people with high triglycerides that I know it is from that, and that's the issue. Medicines will need to be combined with lifestyle changes. They will, you just can't rely on the medicine alone. And so with that, any questions?
Question.
Yeah, please.
Why you mentioned way earlier, you mentioned bile salts. Why wouldn't bile salt supplementation, it's cheap,